everyone. I'm Caroline Jolly. I'm a clinical lecturer at King's College London in the Department of Respiratory Medicine, working in the London Respiratory Muscle Group. I've been working for the past 10 years probably on the relationship of respiratory drive to disordered pulmonary mechanics, respiratory muscle weakness and breathlessness, predominantly in COPD. My work has been led by Professor Moxham and Professor Michael Polke, and there are also some key members of the respiratory muscle group in the audience with me today. The title of my talk this morning is The Role of the Respiratory Muscles in Breathlessness and Exercise Tolerance. So, as we've heard both from Alison and from Lee, under normal circumstances, the healthy, untrained respiratory system is ideally adapted for exercise. And over a wide range of physical activities, alveolar ventilation is closely matched to metabolic demands. And this means that breathlessness isn't usually the dominant exercise-limiting symptom. Mostly people are limited by leg fatigue, and this is particularly the case in cycle exercise. However, breathlessness does become important in special, if you like, normal physiological states. And this includes elderly who have disordered pulmonary mechanics and are also deconditioned in terms of their peripheral muscles. It's also the case in pregnancy, in obesity, and also in athletes, as we heard from Lee, in whom the metabolic demands of the muscles exceeds the capacity of the lungs to deliver oxygen effectively. I'm going to be talking mostly about disease states, partly because of my background being clinical, but also because I think that diseases provide us with a very useful model to understanding the effects of disordered pulmonary mechanics on breathlessness and drive. Breathlessness is common in a whole range of disorders, both malignant and non-malignant. It's dominant in cancer, in respiratory disease, such as chronic obstructive pulmonary disease, COPD, and also in cardiovascular disorders, particularly heart failure. COPD, as I'm sure some of you know, is a very common disease, increasing in prevalence, predominantly caused by smoking and characterized by expiratory flow limitation. And this leads to dynamic hyperinflation during exercise as a consequence of gas trapping. Breathlessness is very common in COPD, particularly in the latter stages of life. However, breathlessness isn't just restricted to people with end-stage COPD. Even people with relatively minor elements of expiratory flow limitation will experience breathlessness during everyday activities. Breathlessness is associated with reduced quality of life and is also an independent predictive factor of mortality. And Chelly et al. Have been instrumental in producing the Bode index, which includes breathlessness as a factor predicting prognosis. As with healthy people, in COPD, both leg fatigue and breathlessness limit exercise capacity. And the degree to which breathlessness limits exercise capacity is to some extent dependent on the task that you ask patients to do. So this is a study carried out by Will Mann et al. In our respiratory muscle lab at King's with Professor Moxham. And in this study, he asked COPD patients to carry out 4 different types of exercise. So they carried out an incremental shuttle walk test, so an ambulatory test, an incremental cycle exercise test, an endurance shuttle walk test, and an endurance cycle exercise test. And you can see that, these are the symptoms that he asked them to report. Breathlessness, SOB here, LE, which is leg fatigue, or a combination of breathlessness and leg fatigue. And you can see that breathlessness was the dominant exercise limiting factor in the walk tests. So the incremental shuttle walk test here, more than 75% of patients reported breathlessness to be their dominant symptom, and in the endurance shuttle walk test, implying that leg fatigue might prevent pulmonary mechanics becoming the limiting factor and reducing breathlessness. This work built on, to a certain extent, work carried out by Killian et al. In 1992. Now, Killian generated a huge amount of data in his lab, and he was able to compare the symptomatic responses of healthy people with those with a range of diseases, but including chronic airflow obstruction. And this is quite interesting. First of all, it was one of the first studies to demonstrate that patients with chronic airflow obstruction were limited by leg fatigue, so L here, in addition to being limited by breathlessness. The other thing to note, however, is that the degree of breathlessness was the same as people who were healthy. However, if you look at the severity of breathlessness relative to the work performed, you will see that the patients stopped exercising at around 60% of their maximum work capacity, compared to healthy subjects who stop at around about 100%. However, the level of breathlessness is the same. So this implies that patients with chronic airflow obstruction are limited by more intense breathlessness relative to the amount of work that they perform. So why should it be that these patients are limited by breathlessness? We can think about this when we consider the neurophysiology of breathlessness and the etiology of the sensations that we acquire. So breathlessness, this is the consensus definition of it, is a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. Now, there are a couple of important points to draw here. The first is that breathlessness is subjective. It's experienced by the person themselves. You can't say how breathless someone else is because that's personal to what they perceive. The other is that there are qualitatively distinct sensations. To a certain extent, they may arise from different sources of afferent feedback, but I think it's fair to say that all of the afferent feedback that arises from the respiratory system contributes to breathlessness in some way. What is this sensory feedback? There is afferent feedback from sensory receptors in the respiratory system, which is our traditional idea of what afferent feedback should be, but also the awareness of levels of neural respiratory drive, so the output of the medullary pontine respiratory centres to the respiratory muscles is important. So this means that we have an ongoing awareness of how much activity we're asking our respiratory muscles to perform. So let's first of all consider sources of afferent feedback, which Emma has already touched upon. And I'm also going to be using some work presented by Jerry Dempsey. So this diagram is a nice diagram because it describes the translation of neural to mechanical output. And we can use this to consider what afferent sources of information the normal mechanics of breathing generate. So breathing starts in the respiratory center, includes activation of inspiratory and expiratory motor neurons, which stimulate and activate respiratory muscles. These respiratory muscles shorten and generate tension and move the chest wall. So our first sources of afferent feedback are those related to respiratory muscle and chest wall function. So the degree of stretch, which is related to changes in muscle length, afferent feedback is provided by respiratory muscle spindles. The amount of tension generated is fed by Golgi tendon organs. There are also respiratory muscle metaboreceptors, which Emma has spoken about. And the amount of chest wall movement is fed back by chest wall, joint and skin receptors. So chest wall movement, if we're thinking about inspiration, generates a negative intrapleural and a negative intrathoracic pressure and a negative airway pressure. Airway pressure goes below atmospheric and we generate inspiratory flow, pressure changes and volume changes. So what are the possible sources of afferent feedback that could be generated from that? Well, there are trigeminal skin receptors around the nose and mouth area, which can sense when air is moving against the face. There are upper airway temperature receptors, which respond to cooling and again give the sense of airflow. And there are also pulmonary stretch receptors, both rapidly adapting and non-rapidly adapting receptors, which sense the degree of pulmonary stretch. In disease states, there are also irritant receptors and juxtacapillary receptors, which I haven't mentioned here. So chest wall moves lung, and then the lung moves gas. And movement of gas promotes gas exchange and changes in oxygen and carbon dioxide tension and acid-base homeostasis. And this activates central and peripheral chemoreceptors, which can also feed back up to the cortex. Now, the first thing to say is that, surprisingly perhaps, mechanoreceptor feedback from the respiratory system is not essential for the sensation of breathlessness. And this was very elegantly and somewhat heroically studied by Gandevia et al., who studied whether the sensation of breathlessness was related to the chemical drive to breathe by undergoing paralysis while still being conscious. And breathlessness was driven by carbon dioxide. And carbon dioxide, the rising stimulus of carbon dioxide was mediated in three ways. One was rebreathing with added carbon dioxide. The second was rebreathing alone. And the third was with a breath hold. And they also had a sham situation as well. Now, this is an example of the results, I presume, from Simon Gandevia himself. And you can look at this with me. So first of all, the thing to say is that the levels of carbon dioxide driven by each of these rebreathing with added CO2, rebreathing alone, and the breath hold reach the same level, both in the control situation and in the paralyzed situation. The other thing to note is that breathlessness, which was measured on the Borg scale, rose to the same levels in both the control situation and in the paralysis situation for all three of the experimental conditions. And the duration of breath hold was also not affected by being paralyzed. So this implies that breathlessness induced by carbon dioxide is actually preserved following total neuromuscular blockade. And this implies that chemoreceptor activity, by increasing central respiratory drive, can induce breathlessness in the absence of any respiratory muscle contraction and the mechanical response. So this idea built on a theory proposed a couple of decades earlier by Campbell and Howell. And this is the theory of length-tension inappropriateness, or if you like, of efferent-afferent mismatch. The basic tenet of this theory is that the basic defect in breathlessness is a mismatch between the pressure or tension generated by the respiratory muscles and the tidal volume that that pressure generation evokes, which is equivalent to the change of length in the length-tension dissociation theory. Put in simple terms, this means that the brain expects a certain amount of ventilation in response to a given amount of respiratory drive. And any deviation of the afferent signal in response to a certain level of efferent drive will increase a sense of respiratory effort and breathlessness. And there is some physiological evidence that backs this up. One example of this is that if you restrict respiratory rate and tidal volume, when neurorespiratory drive is increased by carbon dioxide, this increases breathlessness because the chemical drive and efferent drive is increasing, but you're limiting mechanical output. And so there's a dissociation between efferent drive and afferent feedback. This increases the sensation of effort and increases breathlessness. Secondly, and quite interestingly, you can reduce breathlessness by increasing the amount of afferent feedback when efferent drive is increased. And this has been studied by Hommer's group, who vibrate over the respiratory muscles using some vibrating bars over the chest wall. And if you vibrate over the respiratory muscles, the inspiratory respiratory muscles during inspiration, this increases afferent feedback relative to efferent drive, which redresses the afferent-efferent mismatch, and that reduces breathlessness. However, if you get it wrong, and you vibrate over the expiratory muscles during inspiration, then this isn't the pattern of activity that the brains are expecting. You shouldn't be getting afferent feedback when you're breathing in from the expiratory muscles, and this makes breathlessness worse. So it's quite clear then that understanding respiratory drive is really key to understanding breathlessness. So as I've already touched on, and this is a theory that I'm going to develop over the next 20 minutes or so, is that perception of central respiratory drive by sensory areas of cortex is key to the development of breathlessness. Now, under what situations does respiratory drive increase? Well, this is in some ways complex, but in other ways quite simple, if we just consider it in terms of the respiratory muscles, the load on the respiratory muscles, and the capacity of them to respond. And this is quite pertinent if we're thinking about respiratory muscle training in situations where respiratory muscles are weakened. If the load on the respiratory muscles increases, then respiratory drive must increase to cope with that load. And increases in respiratory drive are perceived as breathlessness. On the other hand, if the capacity of the respiratory muscles is decreased or they become weak, then again, respiratory drive must increase to activate them more and restore their capacity. And again, in this case, respiratory drive increasing will lead to increased breathlessness. Now, there is evidence for this in healthy subjects and also in disease states. First of all, adding an inspiratory resistive load during exercise increases breathlessness in healthy subjects. So in this study by El-Mashawi et al., they imposed an increasing resistive load during exercise. And what they found was that at an equivalent workload, breathlessness was increased as the resistive load increased. Respiratory muscle weakness also increases breathlessness. So again, this is work from Killian's group, and they looked at their large database of exercise studies in healthy subjects and in disease states, and they subdivided the healthy group and the pulmonary group in terms of the strength of their respiratory muscles, using a PI max, so maximum inspiratory pressure, as a way of separating people out into those that were weak and those that were strong. And they found, again, that at equivalent workloads, having weak respiratory muscles increases your perception of breathlessness at that workload. So at this level here, the level of breathlessness in the very strong group is 2, as opposed to in the weak group, it's 6. So I'm going to build on this model by considering chronic obstructive pulmonary disease. Now, COPD is, I think, an excellent model of thinking about breathlessness in terms of load, capacity, and drive. And this is because, unfortunately for the patients, they experience both an increase in the load on the respiratory muscles and a decrease in the capacity. And so they are particularly prone to having this unfortunate combination of increased load, reduced capacity, and increased drive. Now, the sources of increased respiratory load are from airflow obstruction. You remember that airflow limitation is the predominant characteristic feature of COPD. Static and dynamic hyperinflation, which generates increased positive end expiratory pressure, which I'll talk about in a bit more detail in a couple of slides' time. But essentially, you'll remember from your basic physiology that, of course, inspiratory pressure must fall below negative, intrathoracic pressure must fall below negative in order to generate inspiratory flow. So if you are starting from an end expiratory pressure which is positive, this means that you have to overcome a positive pressure before you drive your intrathoracic pressure below 0. In COPD, there is also increased ventilation driven by hypoxia, hypercapnia, peripheral muscle dysfunction, which generates lactic acid at an early stage in aerobic exercise, and by increased respiratory rate. The capacity of the respiratory muscles is also decreased in COPD. And again, Lee touched on this in his talk also. The predominant factor here is that as expiratory flow limitation progresses and emphysema progresses, then there is increased gas trapping and hyperinflation, which puts the respiratory muscles, particularly the diaphragm, at a mechanical disadvantage. The sarcomeres become shortened, the length-tension relationship alters, and the capacity of the muscles to generate force at higher lung volumes is decreased. So, which of these factors relate best to breathlessness and COPD? So, the first thing to say is that it isn't the amount of expiratory airflow obstruction. So this work comes from Jones et al. In thorax in 2001, who looked at the relationship between the level of airflow obstruction, measured by forced expiratory volume over 1 second, to breathlessness-related quality of life, the St. George's Respiratory Questionnaire. And yes, you can draw a regression line through it, but you can see that this is actually a huge scatter plot. There isn't a clear relationship between FEV1, breathlessness, and quality of life. However, hyperinflation and gas trapping relate much more closely to breathlessness. First of all, hyperinflation restricts expansion of tidal volume, which limits ventilatory capacity. So I'll just review normal lung volumes in COPD, which will hopefully make this clearer. So on the left-hand side here, we've got normal lung volumes and lung capacities. So as I'm sure you all know, we start breathing from resting end expiration at functional residual capacity, FRC here. This is tidal volume. The difference between resting end expiration and TLC is inspiratory capacity, so the amount that you can increase your lung volume by, if you like. And end expiratory lung volume is described by changes in expiratory reserve volume and residual volume, which added together make up the FRC. Compare this situation to COPD. So first of all, because of gas trapping and hyperinflation, functional residual capacity is increased and it's much closer to total lung capacity. So you can imagine breathing up here. This means that inspiratory capacity is reduced because FRC is already further up towards TLC. So imagine what happens during exercise. In COPD, dynamic hyperinflation is dynamic. It continues to increase. And so what happens is that FRC is increasing, which means that there's a progressive decrease in inspiratory capacity, which limits how far COPD patients can increase tidal volume and increase minute ventilation, which explains why COPD patients stop exercising at much lower levels of ventilation than in healthy people. The second consequence of hyperinflation, which I've already described, is the development of a positive end expiratory pressure, which imposes an inspiratory threshold load. Thirdly, again, as we've already heard about, hyperinflation induces a functional inspiratory muscle weakness as a consequence of disordered geometry and length tension relationships. And at high lung volumes, the chest wall compliance is altered so that there's a tendency for the chest wall to spring inwards rather than outwards. So again, this is a load that has to be overcome before we can breathe in. So as Lee has already described, we can investigate these in the laboratory by studying the pressures generated during breathing. So this is Malcolm Green, who is modelling an esophageal and a gastric pressure transducer. These are balloon catheters that we have here. And you put these down your nose. One of them goes into your stomach and measures your gastric pressure, which is a measure of intra-abdominal pressure. And one of them goes just above, in the lower esophagus, just above where the crural diaphragm is. And this is an approximation of intrapleural pressure. So we have esophageal pressure as a marker of intrapleural pressure, and abdominal pressure as a measure of abdominal pressure. And if we subtract esophageal pressure from gastric pressure, this gives us transdiaphragmatic pressure, or the pressure that's generated across the diaphragm. So on the left-hand side, we have an example of what these pressure traces should look like if we're healthy. And as Lee's described to you already, esophageal pressure at the beginning of flow, which is positive for inspiration going upwards here. Esophageal pressure starting at around 0 becomes slightly negative. Gastric pressure increases as we breathe in, and gastric pressure minus esophageal pressure leads to a positive transdiaphragmatic pressure. Now, on the right-hand side here, we have the situation in a COPD patient, and I've put this up to illustrate a couple of points. The first is that at the beginning of exercise in this patient, there is a positive end-expiratory esophageal pressure. So this lower line here, which is dashed, is the esophageal pressure. And you can see that it starts above 0. And this represents the positive end-expiratory threshold load that has to be overcome before these patients can breathe in. The second line down here is the end of a free walk. And you can see that the area under curve of the esophageal pressure trace and of the diaphragm pressure trace and of the gastric pressure trace here are all increased, implying that the work of breathing has increased in response to the increased ventilatory load. This degree of pressure generation can be reduced by adding pressure support ventilation. And you can see here that the pressure time product, which is an indication of pressure generation over a degree of time, is reduced in terms of the intra-esophageal pressure, the intrapleural pressure, and also the transdiaphragmatic pressure. So in summary, this shows that there is a positive end-expiratory pressure which has to be overcome. The work of breathing, as measured by the esophageal pressure, the transdiaphragmatic pressure, and also the gastric pressure here, is increased in COPD. And positive pressure ventilation can unload the respiratory muscles, and we can investigate this by looking at reductions in the pressure time product of the muscles in the lab. How about respiratory muscle strength? Well, there are various ways of measuring respiratory muscle strength. I'm sure that Mike Polke is familiar to at least some of you. Volitional measures of respiratory muscle strength include measuring mouth inspiratory pressure and mouth expiratory pressure. There are some limitations to this technique. It gets better with practice, and it's also not a very natural maneuver to perform. And so, at least in clinical situations, this isn't a useful measure of inspiratory muscle strength unless it's definitely negative, i.e. the patient hasn't got respiratory muscle weakness. So a normal value is helpful, but if you get a reduced value, you're still not entirely clear if that represents true respiratory muscle weakness or just means that the patient hasn't done the test very well. These difficulties are overcome to a certain extent by asking the patient to sniff. And we can measure sniff nasal pressure, we can measure sniff esophageal pressure, and we can measure sniff transdiaphragmatic pressure. And sniffing, being a much more natural maneuver, isn't prone to the same limitations to a certain extent as mouth inspiratory pressure, although of course it is still a volitional test and so suffers from those limitations. So as Lee has already described to you, we can measure diaphragm strength non-volitionally by stimulating the phrenic nerves. And we in our lab, like in Lee's lab, use magnetic stimulation. And we most generally use bilateral phrenic nerve stimulation, as shown by this gentleman here. Oops. And this, again, is an example of the traces that you might expect. So on the bottom here, we have esophageal pressure, above this gastric pressure, and above this transdiaphragmatic pressure, which you'll remember is the difference between gastric and esophageal pressure. This is stimulus artifact, and following a stimulation, you get a decrease in esophageal pressure, an increase in gastric pressure, and an increase in transdiaphragmatic pressure, which we can measure as a difference between the peak and the baseline. Now, using this technique, you can show that transdiaphragmatic pressure is reduced in patients with COPD, particularly as hyperinflation progresses. Now, this is understandable if you consider what happens in terms of pressure generation as you sort of artificially inflate the respiratory system. And this has been shown by Mike Polke's work, and he looked at transdiaphragmatic pressure generation in response to increasing and decreasing lung volumes relative to FRC. As lung volume increases, you get a continuous decline in transdiaphragmatic pressure generation, mostly as a result of reduction in intrapleural pressure. It's important to realise, though, and this is work by Similovsky, that although twitch diaphragmatic pressure is reduced in COPD, if you correct for hyperinflation, these patients are actually as strong and even a little bit stronger than healthy matched controls, which implies that the muscles aren't intrinsically weak, it's a function of the disordered mechanics induced by hyperinflation. So going back to our diagram, we've considered the evidence that the load on the respiratory muscles is increased in COPD, the capacity is decreased, and this should result in an increase in drive and an increase in breathlessness. The other consequence of COPD, in addition to increases in load and weakness, increasing breathlessness, is that there's a disconnect, if you like, between neurorespiratory drive and the mechanical output. And this is important if we recall back to the beginning, because this is going to increase the disparity between efferent drive and afferent feedback. So this was, again, very elegantly described by Sinderby et al. In 2001. And they exercised COPD patients on a bicycle, and they measured neural respiratory drive by measuring the diaphragm electromyogram, so a measure of diaphragm muscle activation. They measured the mechanical output in terms of transdiaphragmatic pressure and related this to minute ventilation. So you can see that as minute ventilation increases, as you would expect, neural respiratory drive is increasing. Respiratory drive is increasing ventilation. However, you'll notice that the mechanical response and the ventilatory response is limited at high levels of drive. So drive continues to increase as exercise progresses, but the pressure generating capacity of the patient's respiratory system is limited, so that even though drive is increasing, the mechanical output isn't, and ventilation becomes limited at a relatively low level. So why should this be? Well, again, we can come back to our understanding of normal respiratory mechanics and ventilation. So just to recap, we have respiratory drive, activating muscles, inducing respiratory muscle shortening, tension generation, changes in the shape and dimensions of the chest wall, which increases intrathoracic volume, decreases intrathoracic and airway pressure, which allows flow to occur, the lung inflates, and ventilation begins. Consider, though, what happens in COPD, and you can understand that there is a disconnect between levels of neural respiratory drive and the mechanical output of the respiratory system. So we start again with high levels of respiratory drive, but there is expiratory airflow limitation, hyperinflation, and diaphragm muscle shortening. And so you can see that it is difficult for all of this respiratory drive to be translated to respiratory muscle tension generation and movement of the chest wall. This limits tidal volume expansion. In addition, because airways resistance is increased, there is a reduction in elastic recoil, and you remember that there is an inspiratory, there's an increased expiratory pressure which has to be overcome before inspiration can start. So there's a lot of neuromechanical uncoupling. So this will increase the mismatch between efferent and afferent drive and increase breathlessness. And it will lead to a disconnect between neural activation and mechanical output, which again will contribute to the sense of respiratory effort. So understanding neuromechanical dissociation is important to our understanding of breathlessness. The other reason it's important, and why I've taken some time to discuss it, is because you can see that in patients who exhibit neuromechanical dissociation, Using mechanical and ventilatory measures of respiratory drive are really useless because they will always underestimate how much drive there is. So you want to get as close to the brain as you can possibly get. Now, it's impossible to stick electrodes into your brainstem when you're awake, but you can, as we've discussed, measure the activation of the respiratory muscles by using the electromyogram. And in particular, the diaphragm electromyogram is useful because this is the main muscle of respiration. So in our lab, we use a Multipair esophageal catheter, which again goes down your nose. Quite fond of putting things down our noses in our lab. And this is me in China doing some work in a Chinese lab. And we've got a collaborator in Guangzhou, Professor Lo, who has really been instrumental in our work by developing our Multipair electrode catheters. And these are examples of traces in healthy subjects and in COPD. So first of all, just to point these things out, this here is a QRS complex here. So you also get a nice ECG, which can be more of a hindrance than a help at times. And this extra activity that you can see relative to baseline is inspiratory diaphragm EMG. The other thing to point out before I explain these traces is that in order to be able to compare the EMGs between people, you need to relate this to a maximum activation. And this is because there are differences in muscle fiber orientation and impedance, which will confound any differences in the absolute level of EMG that you might see. So in order to get a maximum activation, we ask people to do some maximum inspiratory maneuvers. And this includes breathing up to TLC, sniffing, and performing a maximum voluntary ventilation maneuver. So in healthy people, you'll see that there is barely any perceptible EMG activity compared to a lot of activity during a maximum voluntary ventilation maneuver. And if we quantify this and express diaphragm activity relative to maximum, resting EMG activity in a normal subject at rest is around about 8% of maximum. It increases slightly with age to about 11%, but is the same in males and females, which is quite interesting considering the possible differences mechanics that Lee suggested. This trace on the right-hand side is an example of EMG activity in severe COPD. Now, you can instantly see that there's a lot more EMG here than compared to the healthy person. And if we compare resting EMG to maximum EMG, we're reaching levels of 45%, even at rest. So you can imagine that the poor COPD patient hasn't really got far to go until they're reaching almost maximal levels of drive, even before they start doing anything. This is work that I carried out a couple of years ago during my PhD, and this compares levels of neurorespiratory drive in terms of diaphragm EMG in healthy subjects and in COPD. And as I've already described, levels of neural drive in COPD are much greater and also correlate well with lung function, airflow obstruction, and hyperinflation. Neurorespiratory drive is also very closely related to breathlessness, both in healthy subjects and in COPD. So this data was collected in China, and we got patients to exercise on a bicycle with the EMG catheter in place, and related neurorespiratory drive measured in terms of diaphragm EMG to breathlessness. And you can see that after a period at the beginning where breathlessness doesn't increase very much, there's a linear relationship between increasing drive and breathlessness, which is in keeping to the idea that we're aware of the levels of respiratory drive that we're sending down to our respiratory muscles. This relationship can also be observed in healthy subjects and in other patients who also exhibit chronic airflow obstruction. And so this work was carried out by Charlie, who's in the audience, in healthy subjects and in cystic fibrosis. At the top here, we've got increases in diaphragm EMG during exercise, increases in breathlessness during exercise, and increases in minute ventilation during exercise. The open circles are healthy subjects, and the closed circles are cystic fibrosis. And like in COPD, there's a very close relationship between EMG activity and breathlessness during exercise, both in healthy subjects and in cystic fibrosis. In healthy subjects, there's also a good relationship between ventilation and breathlessness, which you'd expect because in healthy subjects there is no neuromechanical uncoupling. However, you'll notice that in cystic fibrosis, and this also occurs in COPD, that as drive and breathlessness increase, minute ventilation plateaus because of the disordered pulmonary mechanics. And so you can experience increasing levels of breathlessness without any changes in ventilation, which really goes back to my point earlier that if you're wanting a good marker of respiratory drive that's going to relate to breathlessness, in disorders characterized by neuromechanical dissociation, minute ventilation and mechanical output are really useless. The relationship between breathlessness and neuromechanical dissociation has also been studied in a great extent by O'Donnell's group in Canada. And they carried out this study in 2006, which looked at the relationship between breathlessness, ventilation, and neuromechanical dissociation in patients with COPD before and after giving them a long-acting bronchodilator, tiotropium. So the black filled-in circles here are before tiotropium, and the open circles are after tiotropium. I'll just concentrate on the placebo condition first of all. So in the top left-hand corner, we've got the relationship between exercise time and breathlessness. So breathlessness increases with time, and then at around about 3 minutes, there's a sudden upward inflection in breathlessness, which he termed the breathlessness threshold. This breathlessness threshold at around about 3 minutes is related to the point at which ventilation starts to plateau, which is the point at which pulmonary mechanics become limiting. And so already we can think that maybe at this point there is a dissociation between neural activation and mechanical output, which is increasing the sense of effort. When ventilation becomes limiting, this is the point, this is mirrored by the lack of increase in tidal volume. So up until 3 minutes, tidal volume is able to expand as exercise continues, but at this point here, tidal volume can no longer expand. And this is related to a reduction in inspiratory capacity down here, which you'll remember is a marker of hyperinflation. So as hyperinflation progresses, inspiratory capacity reduces. And so this reduction in inspiratory capacity indicates the point at which hyperinflation becomes limiting by impairing the ability of the patient to expand their tidal volume. So all this points to the idea that when breathlessness starts to increase, this is in response to a disparity between the neural drive and the mechanical output imposed by hyperinflation. Now, breathlessness in COPD is closely related to hyperinflation, as I've already discussed, and tiotropium is a bronchodilator and reduces hyperinflation. So we would expect that if tiotropium works, it should work by reducing hyperinflation, which should improve pulmonary mechanics, leading to greater expansion of tidal volume and increasing the capacity of these patients to exercise, and also by improving neuromechanical coupling because we're reducing hyperinflation. And this is what he saw. So in the open circles here, we can see that breathlessness, both at the breathlessness threshold and also at isotime, was reduced. There was no change in the minute ventilation at this point, but you can see that tidal volume has been increased, which means that there has been some reduction in limitations to tidal volume expansion, and inspiratory capacity was reduced. This was associated with an improvement in neuromechanical coupling. And the measures of neuromechanical coupling that O'Donnell used in this study focused on inspiratory pressure generation and tidal volume. So I'll draw your attention to this graph down here. So this measure here is esophageal pressure relative to the tidal volume produced. So if you like, it's the amount of inspiratory pressure that you have to generate a given amount of tidal volume. So if neuromechanical coupling improves, then you need to produce less inspiratory pressure to generate a given amount of tidal volume. And this is what he found after tiotropium, was that at the breathlessness threshold point, neuromechanical dissociation was reduced after tiotropium compared to placebo, and this was associated with reductions in breathlessness. So I've used the example of COPD, and I hope I've persuaded you that load capacity, increases in respiratory drive, neuromechanical dissociation, and an increase in efferent-afferent mismatch are all important to breathlessness. And we can understand these by understanding respiratory muscle physiology and respiratory drive. I should point out that there are many diseases in which neuromechanical dissociation and efferent-afferent mismatch occur. These can be disorders in which the load on the respiratory muscle is increased, either because compliance is reduced in fibrosis and edema, in heart failure, chest wall disorders such as in pleural disease, kyphoscoliosis, obesity, and is also manifest in disorders in which the respiratory muscles are weak. I've discussed hyperinflation, but respiratory muscle weakness of the muscle itself is also a problem in myasthenia gravis, Duchenne muscular dystrophy, and in patients with critical illness neuromyopathy. So one possible target for inspiratory muscle training would be to improve respiratory muscle capacity, which will reduce neuromechanical dissociation, improve efferent-afferent mismatching, and reduce breathlessness. I think one challenge, though, is for us to understand the degree to which improving inspiratory muscle capacity alone can help when the patients are always working against a fixed load. And I hope that in the future, by using some of these more detailed physiological techniques, we'll be able to understand that a bit better. Thank you.